Hi, Wendy.
Hi, Court.
How are you?
Good.
Happy Saturday.
I know.
All right, Courtney, you're good to get started if you haven't already.
Perfect. Thank you, Charlene.
Yeah, of course.
All right, guys. So this is definitely going to be informal. Feel free to ask questions during the middle. You're not going to interrupt me. It's perfectly fine. I'll try to keep an eye on the chat if you want to type questions there also. So my name is Courtney Carr. I am a nurse practitioner at the St. Jude Affiliate Clinic at Novant Health. And we do see pediatric patients there. I've been working with hemophilia patients since 2013, and I'm also hemostasis nursing certified. Today we are going to discuss the basics of hemophilia. All right. So to understand hemophilia, I really feel it's helpful to understand hemostasis. And what that means is that's a process of blood clotting within the body that helps to prevent and to stop bleeding. So the process of hemostasis, it is a very complex process. There are multiple components of the blood clotting system, and they're activated in response to a vessel injury, and that helps to control the bleeding. So once the process is triggered by the injury to the vessel, then you're going to see vasoconstriction, and that helps to reduce the blood flow to the area, and then platelet plug formation occurs. The coagulation factors are then activated and generation of thrombin occurs. The thrombin converts fibrinogen to fibrin, which you can see here on the slide, and that helps to form a stable blood clot. After that, the coagulation inhibition occurs, and that prevents the clot from becoming too large. We're going to try to watch a video. It doesn't look like it wants to work. Bear with me. So the video just gives a simplified view. Oh, it's not going to work. Sorry, guys. All right. So it just basically gives a simplified view and you can see how it works in the video. You actually see how the vessel is injured right in this area, and it just shows you how the platelet plug forms. The problem that we see when you have hemophilia, the process of hemostasis is interrupted. And so that makes your blood not be able to clot the right way. So with hemostasis, you have to have an adequate amount and function of von Willebrand factor, platelets, and clotting proteins, and all of those stop the bleeding. So if you don't have the adequate function and amount of those, then obviously you are going to have bleeding. And that's what happens with hemophilia. So sorry the video is not working. I actually do find it helpful. If you guys want to see it, I'll send the link to Charlene, or I can try to include it later, just if you guys are interested. No, it's not the most thrilling topic. All right. So what is hemophilia? Hemophilia is a genetic disorder, and it occurs on the X chromosome. It's due to the absence or deficiency of a clotting protein, and you either have hemophilia A, which is a deficiency of the factor 8, or hemophilia B, which is a deficiency of the factor 9. And there are many proteins that help clotting within your body. Factor 8 and factor 9 are just two of those. Hemophilia affects about 30,000 people in the US, and worldwide about 400,000. It has been documented since biblical times, and it was sometimes referred to as the royal disease because Queen Victoria of England actually was a carrier. So as we said, hemophilia is an X-linked, it's a recessive disorder. It is thought that about 30% of cases are spontaneous mutations. Now we think that more of the families with the spontaneous mutations probably have females that have hemophilia, and we just weren't aware until more recently because females aren't typically diagnosed with hemophilia. Normally males are diagnosed with hemophilia shortly after birth, and for females being diagnosed, it's a little later. It's a little harder for women to get a diagnosis for hemophilia. So a lot of times it's either in like adolescence or later in adulthood. It is still very controversial of when to test women for hemophilia. And like I said, they do have more difficulty getting a diagnosis. And because of that, we see increased injury for them. So this is a graphic from Hemophilia Federation of America, and it just shows you how you can inherit hemophilia. So you see on this graphic, you have a dad that has hemophilia, and he's going to have two daughters that are carriers. His sons will not be affected. And on this graphic, you have a mom who's a carrier. So there's a 50% chance that her son will be affected, and a 50% chance that her daughter will be a carrier. Now, this is a graphic from them that to me is very powerful because this does show how women can have hemophilia. So you can see the male has hemophilia and the female is a carrier. So there is a 50% chance that their son will have hemophilia and a 50% chance that their daughter will have hemophilia. Their other daughter would have a 50% chance to be a carrier. So what does that mean when I say a carrier? Well, the graphics before tell you how you can have hemophilia. It doesn't tell you the symptoms necessarily for females. So the females who have hemophilia, because they have, a carrier, they have one altered X chromosome, and they can have bleeding symptoms. So they can also have the altered gene on both of their X chromosomes, and they can pass the affected gene to their future generations. So there's currently no designated way to refer to a woman who carries the single gene of hemophilia but has symptoms of hemophilia. Most of those women today are referred to as a symptomatic carrier, but really they should be addressed as a hemophilia patient, because if you call them a symptomatic carrier, a lot of times with insurance, they're not going to get covered for factors if they need that. And it becomes a battle. So we really need to address females with bleeding symptoms as hemophilia patients and not carriers. And another reason is I hear a lot from other medical providers that, well, women have two X chromosomes. So if one is unaltered, then they shouldn't have bleeding. They should be fine. But honestly, that is a myth. Um, Even with the one altered X chromosome, you still can have bleeding symptoms. Um, it doesn't always produce an adequate factor level for you, so you will still have bleeding. And the good X or the unaltered X chromosome actually can be silenced by the other. Um, and so you will have some symptoms of hemophilia. So basically, when you're deficient, you're going to have symptoms. So if you have an altered X chromosome, you can't have symptoms. I hope that's clear. Does anybody have any questions about that? Okay. All right. So how do we detect hemophilia? We test blood samples. That's how we confirm hemophilia. But most males are diagnosed, especially severe males, during the newborn period when they get circumcised. Most females are diagnosed around the time of their menstrual cycle. Other ways that we found patients with hemophilia is during dental procedures, tonsillectomies, trauma. Um, we had a patient who was out hunting and somehow he was bow hunting and he got skimmed by the bow or by the arrow, and it bled for probably 2 weeks on and off. It just wouldn't stop. And it was on his leg. I think he was 14 at the time, and he came in and he was found to have mild. So, because he was mild, he wasn't found in the newborn period, and he went most of his life without realizing that he actually had hemophilia. So as we previously discussed, there are two main types of hemophilia. Hemophilia A is definitely the most common. Each type can have different severities, and we'll discuss that next. About 50 to 60% of patients with hemophilia are classified as hemophilia A, and about 45% of B are severe. 50 to 60% of hemophilia A are severe. And it's unknown how many females actually have hemophilia. So here's the severity. This is a classic diagnostic criteria for hemophilia. This is solely based on male pattern bleeding. So this doesn't really fit for women, but certainly we definitely use this for our male patients. Severity tends to run in families also. So if you have a family member with mild, generally you're going to be mild as well. We don't tend to see someone with mild have someone in their family with severe disease. It just doesn't work like that. With mild hemophilia, the factor level is over 5 or 6 to 40 of a normal clotting amount. And these patients tend to have bleeding only with trauma or serious injury, sometimes with surgery like a tonsillectomy, or like the patient I said that had the bow injury, certainly for that type of thing. They, like I said, may not be diagnosed until they have surgery, dental procedures, like a tooth extraction. That's a big thing. And those result in prolonged bleeding, and that's how we find the patient. Moderate hemophilia is between 1 to 5 of the normal amount of clotting factor. And these patients also tend to have bleeding after injuries or surgeries. They occasionally will have spontaneous bleeding. That's more rare for them, but definitely after trauma or um, surgeries. For severe hemophilia, it's under 1% of the clotting factor. Severe patients do have spontaneous bleeding. They will bleed following an injury. Um, and like I said, they have a spontaneous bleeding into their joints, into their muscles. Um, it can be pretty painful for them. A symptomatic carrier is a female that has 40 to 60% of the clotting factor. And females with hemophilia do show similar symptoms of other hemophilia patients, but numbers don't really correlate for them for bleeding. The normal range of clotting factor, you can see from the graphic, is 50 to 150. And like I said, there's a huge difference in the quality of life for a severe patient versus mild patient. And a lot of that just has to do with the spontaneous bleeding. So for women with hemophilia, like I said, numbers really don't tell the whole story, because a woman with hemophilia could be classified as mild based on her factor level, but she may actually present more as a severe based on her symptoms. So diagnosis and management of hemophilia for women, and really for anyone, should not be just based on their levels. It should be based on their symptoms. Because we do have some moderate patients even that are on prophy because they have a lot of bleeding symptoms like a severe patient would. In our center, actually, we treat a mild based on numbers female patient with prophy because she has severe bleeding. Her brother also has severe hemophilia, and she bleeds very similarly to how he does. Now his levels are under 1 and hers are around 20, which, as I said, would classify her number wise as mild, but she really bleeds like a severe. So she got put on prophylaxis because she was having a lot of joint bleeds too. So factor levels can vary from carrier to carrier also, and only about a third of carriers actually have symptoms. So individual carriers with the same factor levels may not have the same type of bleeding. So we might have one patient with a 23% factor 8, and she's not going to have any problems. And we have another patient with a 23% who has joint bleeds. So it really varies person to person. That's why I say treatment really has to be individualized for every patient, not just females. And just to show, how the diagnostic criteria is based on males, a male with a 17% factor level would be diagnosed as a mild patient, but a female with a 17% would be diagnosed as a symptomatic carrier. And that's why I call these patients hemophilia patients, because truly they are. So how do patients present with their bleeding? Bleeding, like I said, does depend on severity overall. Severe patients can bleed without any trauma, without any reason. They usually have joint problems later in life, though we're seeing that change a lot with prophylaxis and different medications that are on the market. When I first started in hemophilia, I had a 3-year-old patient that had a joint bleed, and he's now 10, but It's because he had cowboy boots, and cowboy boots have a little heel. And so those had the heel, and then they weren't actually big enough for him. They were a little bit too small, and that actually caused an ankle bleed for him. Um, so it's interesting, to me, because I don't have a child with hemophilia, but to see the things that actually can cause bleeding. You wouldn't think a pair of cowboy boots would cause a problem. Um, Moderate patients can also have joint problems. Like I said, we actually treat a couple moderate patients for bleeding. Mild patients rarely have any type of joint problems um, because they typically bleed after an injury or a surgery. So, where do hemophilia patients bleed? Everywhere. They can bleed everywhere. They can have nosebleeds, gum bleeding, mouth bleeding, GI bleeding. I've seen a patient have eye bleeding, which was super creepy if you've never seen that. She actually said, it was a female patient. She said that her brother was terrified of her after that for for a few weeks. Um, you can have soft tissue bleeds, muscle bleeds, joint bleeds, um, bleeds in the renal system, the throat, brain. So now let's talk about the different types of bleeds. So for joint or muscle bleeding, typically with early symptoms, you're going to see numbness, tingling, sometimes like an achy type pain in that area, and especially with younger children, a reluctance to use that extremity. For late symptoms, you're going to see numbness, warmth to touch, swelling, and decreased range of motion. Um, do not use heat on bleeds because that can actually lead to vasodilation, and that can make bleeding even worse. So if you remember when we first started today and talked about how when there's an injury to a vessel and vasoconstriction occurs to help prevent bleeding, heat doesn't allow that to happen. So you can actually have more bleeding if you use heat versus ice. Ice is better. And don't forget that fingers and toes are also joints. I know that those little guys are hard to remember, but they can definitely have bleeds also. So for joint bleeding in females, females with all severities of hemophilia have been shown to have reduced joint range of motion, and that reduced range of motion occurred across all age groups. Um, so, I feel like we're getting more towards a part where females are being diagnosed and being treated, which is good because, everyone should have the same quality of life, male and female, that have hemophilia. So for life-threatening bleeds, certainly if you have any type of life-threatening bleed, immediate factor infusion is 100%. You have to do that. With head bleeding, that remains the leading cause of death for hemophilia patients. So factor should be infused immediately. Hemophilia patients that have life-threatening bleeding, like in their neck or their throat, head, hip, they will typically be hospitalized just because we want to monitor and make sure that their factor levels are staying where they should. For abdominal and GI bleeding, the primary symptom is pain, but you can also have some nausea, some blood in your bowel movement. So just things to watch out for if you have any problems. So for hip bleeding, it can definitely be life-threatening. And on this graphic, you can see where this muscle is. And on this graphic, you can see the pain presentation if you have a bleed here. You can see that this is a really large area, actually on both sides where the pain can kind of refer. That's why it can be life-threatening, because it is such a large area where you can have that bleed. And when someone has a hip bleed, the number one thing I look for is if a patient is laying down, they're not going to be able to bend their legs all the way down. They're going to have to stay like hyperextended. They're not going to be able to lay down flat. We took care of a patient who was actually a mild hemophilia patient, and he decided that he wanted to start working out. He was what he classified himself as a couch potato prior to starting the insanity workout videos. And unfortunately, during that, he had a hip bleed, and he came in a wheelchair because he could not walk. When he tried to stand, he could not stand up straight. He had to stand bent over. Um, he ended up having 2 months of physical therapy and multiple doses of factor to get the bleed under control. And part of the reason for that was when he was doing the insanity workouts, he thought that he had pulled a muscle and didn't even think, because he's my own patient, that it could have been a bleed. So it did go on for several days before he ended up coming in. And that's why, like I said, it's such a large area. By the time we saw him, there was a lot of bleeding and pain that he was having. So it took a long time. I think it was about 2 months overall that he really felt back to normal. Um, and as a reminder, do not use heat, because he was using heat since he thought it was a muscle pull and not a bleed. So other bleeding we see is, like I said, nose bleeding, mouth bleeding, gum bleeding. Women can have heavy menstrual bleeding, oozing from cuts, like the patient with the arrow. And keep in mind that mild bleeding may even need treatment. So when kids get teeth coming in and have mild bleeding, sometimes that needs a dose of factor and not just something like Amicar. So what are complications of bleeding? There are several, but the most common that we see is chronic and acute pain. And so I want to discuss more about pain with you guys today. So how does pain start? How does this process start? When you have bleeding, it starts from the breaks of the tiny blood vessels, and those breaks can sometimes be caused by an injury. In a person with hemophilia, it can be spontaneous, like we talked about. The early signs are heat, tingling, and bubbling. And then what happens is the blood starts filling the joint cavity, which causes pain and swelling. And the bleeding will continue until factor is infused. So if you don't infuse factor right away, it can stop once the joint space is filled up. And you can see here what the healthy joint looks like, and then with a bleed, what that looks like in that space filled up with blood. So joint damage can occur after several bleeds in one area, or even after one serious bleed. So that's why we think that prophy is so important, or prophylaxis, because it helps to prevent bleeding. Joints that we typically see affected are elbows, ankles, and knees. But like I said, it could be any joint, even fingers and toes. So we know that pain is a complication of hemophilia, but it's not well understood. Pain in people with hemophilia often goes unrecognized, and because of that, it's undertreated in both adult and pediatric patients. Studies have shown that it's not often recognized because of words that are used or not being asked about pain during a bleed. And pain honestly can have a lot of impacts on your life. Both physical and psychological aspects of your life can be affected by pain, including your ability to go to work, to go to school, to perform activities of daily living. Certainly if you can't stand up to get out of bed, how are you going to stand up to get dressed? Um, Sleep patterns can be affected. Um, this can all lead to emotional states like depression, anxiety, anger for sure, at not being able to do things that you want to do, issues with self esteem. We see that especially in the adolescent population. Um, Social, familial, marital relationships can all be stressed and impaired because of this. Sometimes patients are socially isolated because they feel like they can't do what they normally do. So they just want to be by themselves. Um, and then also a financial impact if you're missing a lot of days of work, or you're on disability, or even, stress of school if you're having to miss a lot of days of school. So really pain impacts your quality of life 100%. So what are the types of pain that I'm talking about? Studies have shown that both patients and providers have difficulty distinguishing the differences between acute and chronic pain. So the properties of the two types of pain are perceived to be similar, and people with hemophilia often use the same words to describe acute and chronic pain, and so that makes it a little harder to distinguish. And then to compound the problem further, a lot of hemophilia patients have more than one kind of pain at the same time. So you can have chronic and acute pain at the same time, and that can make it harder to distinguish and treat. The main difference that we see between acute and chronic pain is one of intensity. So acute pain is generally described as intense and it comes on really quickly. Chronic pain, unlike chronic pain, acute pain normally tells us that something's wrong, like a bleed. And if it is a bleed that's causing the pain, then you can treat with factor and hopefully that'll be resolved. Um, Chronic pain it can be intermittent or continuous, but it occurs more than once a week for at least 3 months or longer. And for a subset of people with hemophilia, their chronic pain is actually related to arthropathy, and that causes their persistent pain. So, how do we treat pain? Like I said, you can certainly give factor if you feel like the pain is related to a bleed. Always be on alert when it comes to, sorry, my computer is about to shut down. Always be alert when it comes to new or different pain. New pain can signal a bleed, so we want to treat that. And then, certainly if you're giving a dose of factor and the pain is still persisting, then it's likely not related to a bleed and we need to look into other causes. Because typically if it is a bleed, then the factor is going to stop the bleeding and that can stop the pain. Studies have shown that the sooner the bleeding is stopped, the less damage will be done to the joint. Proactively preventing bleeds has had a positive impact as well on reducing joint damage and chronic pain. And studies have shown that there are huge advantages of prophylactic treatment versus on-demand treatment because of that. So what do we use to treat pain medication-wise? There are a ton of different analgesics that are available. Acetaminophen or Tylenol is one. The biggest concern with Tylenol is you just have to be aware of the risk of liver complications, especially in any patients that have hepatitis. The other concern with Tylenol is it's in a lot of different medications. So you have to make sure that if you're taking Tylenol, that other things you're taking don't have it as well. Like narcotic pain medicine sometimes will have Tylenol in them as well. There are also medications called NSAIDs, and they come in two different types. COX-1 inhibitor are medications like Aleve or Motrin, ibuprofen. Those can occasionally be used. I don't like to use them because they actually interfere with your platelets, which can lead to easier bleeding. So I don't like to use those. COX-2 inhibitors are prescriptions like Celebrex, and they do not interfere with platelet function. So that's my preference for patients. There's also decreased side effects with the Celebrex. We also can use tramadol. It has less potential for abuse than a narcotic pain medicine if that's a concern for a patient. Um, and then, strong opioids like oxycodone, if that's needed, certainly is available. Those, the only downside is there are lots of side effects. You can have constipation, tiredness. It's not something you can really take during the day if you're trying to go to work. Um, and it can present a risk of abuse or addiction, but honestly, that's a pretty low risk. So it's something that I just talk to patients about, and we just keep an eye on it. Certainly if you are having pain and you feel it's not well managed, I would definitely talk to your hematologist about that, because there are several steps that you can take to, help them understand better what's going on. Um, for one, ensure that at every single visit that you go to, that they're assessing your pain and making sure that you're not having any. That honestly should be part of your vital signs to check with your pain level as well. Also, if you're having pain, be prepared to describe that. Um, I have a hard time with some patients because they'll say, oh, well, 3 weeks ago, I had a sharp pain in my leg. Well, how long did it last? What did you have to do to help it? Did it go away on its own? If you have those answers, that is a lot more helpful for your provider, because that helps us know how to treat it. If you say, I had the most intense burning pain 3 weeks ago, and it was on this day, and it lasted for 2 hours and went away with Celebrex, that is a lot more helpful and lets us know, okay, we need to look at this more in depth, or, just keep an eye on it. So also discuss the impact of pain for you. Is this impacting your work, your school, your family life, your marriage, your mood, anything like that? Your provider definitely wants to know. And, lastly, if you're talking to your hematologist about all this and you're still having pain and it's not getting treated, ask for a referral to a pain specialist. That's what they do. And, they'll certainly help you. So other methods of treating pain, there are other methods that do not involve medication, or you can use in conjunction with medication. So we refer to this as a multimodal approach. And the goal of multimodal is not to replace a standard treatment like a medication, but to provide complementary treatments that can be used along with the standard treatment. So the non-pharmacologic method is rice. I'm sure you all know about rice. Definitely rest, ice, elevate. That's a big thing. There are many types of complementary therapies as well. And there are a lot of studies that have been done on complementary and alternative medicine, but limited studies for these therapies with hemophilia patients. One method is actually acupuncture, which when I read about this and studied this, I was surprised, because you wouldn't think that using acupuncture in a hemophilia patient would be a good idea. But small studies on acupuncture demonstrated a huge improvement in range of motion of the joints and the ability to control pain. The people in this study did recommend making or getting the factor level up to about 15% of what the normal is prior to acupuncture. But in all the studies that were done, there was no bleeding, no pain, no swelling or infection afterward. Another type of alternative therapy is hypnosis. And studies have been done on this, including self-hypnosis, and they demonstrated significantly less bleeding and a decreased need for infusions. So I thought that was pretty interesting. There's also something called biofeedback, and it's a non-invasive method. It's safe for patients with bleeding disorders. And the ultimate goal of biofeedback is to perform self-relaxation. There's also cognitive behavioral therapy, and this is when a therapist helps you to reframe and refocus your beliefs on pain. There's also mind body medicine, and it uses techniques like distraction, yoga, deep breathing, and meditation that will help with pain. There's also hydrotherapy that helps with increase in range of motion and decreased pain. This also helps to increase your muscle strength and your flexibility and coordination, which can all lead to decrease in pain as well. There's something called Reiki. I don't know if you guys have heard of it, but it's a healing technique, and it uses touch, and it channels energy and moves to more natural healing processes. There's a center near us that uses Reiki therapy for oncology patients that are in pain, and the patients report a huge improvement after that therapy. So I don't know of anyone in the area that uses it for hemophilia patients, but I've definitely seen personally with oncology patients a huge improvement in their pain. Spiritual healing also has had rigorous studies that have shown a reduction in pain. And transcutaneous nerve stimulation, like a TENS unit, it's low electrical impulses, and they stimulate the peripheral nerves, which allow the release of endorphins to prevent pain. And there's several other techniques that have been shown to improve chronic pain through rewiring of your brain by shifting attention away from the pain. These include meditation, like I said, music therapy, and guided imagery. Another option for treating pain is lifestyle changes like exercise. According to the World Hemophilia Foundation, physical exercise and sports are one of the basic foundations in the treatment of hemophilia. So we know physical fitness improves joint flexibility and strength. There are also positive psychological and emotional benefits, and exercise may relieve pain by improving muscle strength, joint range of motion, flexibility, coordination, and balance. We know that stronger muscles tire less easily, and that results in extra support and protection for the joint, and it also reduces the stress and strain that can cause pain. Improved mobility of the joint will result in better alignment of the joint and decreased stress on its surrounding structures. Physical therapy is also part of a multimodal approach, and we definitely recommend it for management of pain and hemophilia. Several studies have demonstrated that physical therapy is associated with improved muscle strength, range of motion, and flexibility, which can slow the progression of joint damage as well. And results from the National Pain Study have shown that physical therapy is underutilized, which I think we all know in this field. And only about 30% of providers use it as part of a pain strategy for their patients. Other studies have shown that physical therapy improved walking distance, provided stable range of motion in the knees and the elbows and the ankles after 5 years, and it decreased pain intensity by 26%. So physical therapy is definitely a bonus, and we like to use it where I where I am. So now that we've discussed the treatment of pain, let's discuss the treatment of hemophilia. Any questions so far? All right. So there are several treatments for hemophilia. They include factor replacement, non-factor products, Stymate, which is currently on recall, and agents like Amicar and Lacida, and then supportive measures like ice. So I have this picture right here. This is a cool little product for shoulder bleeds. It ices, and it can actually ice down the arm. I think that's super cool. But supportive measures like ice, rest, and immobilization. So first, talk about factor VIII replacement. These products are either regular half-life or extended half-life. They are given IV, generally IV push, and they can be given through a port or peripheral access. And they can be used for prophylaxis or on demand. I have seen one continuous infusion, and that was done in a hospital. So those are really rare. Generally, we can treat patients with just IV push. For factor IX replacement, same as far as half-life. They're either regular or extended. It's given IV push through either port or peripheral IV. And these products can also be used for prophylaxis or on demand. Factor IX products do have a longer half-life than factor VIII products. And some of their extended half-life products can last for up to 2 weeks with one infusion. Another product that came on the market about 5 years ago is called Hemlibra. It is not a factor product. It is used for only hemophilia A patients, but it can be hemophilia A patients with or without inhibitors, and it can be started in all ages, newborn and up. And we actually have a female patient that is on this in our clinic. So Hemlibra works as a bridge. So you can see here how you have factor IXA and factor X, and Hemlibra brings those together like a bridge, and it allows the coagulation process to continue without needing to replace the factor VIII. With Hemlibra, everyone is started on a once weekly 4-week loading dose, and that builds up the levels of the Hemlibra in the blood. And then starting in the 5th week, you start maintenance, and your maintenance dosing can be either once a week, once every 2 weeks, or once a month. It is a shot that's just given under the skin, and it's only for prophylaxis. So if you have any bleeding or breakthrough bleeding with Hemlibra, then you have to have a factor VIII product as a backup, or if you have inhibitors, you have to have a bypassing agent as a backup, just in case. And even if you do have a breakthrough bleed, you continue your Hemlibra like you normally would. Once factor VIII is introduced and you have Hemlibra on board, the Hemlibra takes a back seat, and the factor VIII will then move where the Hemlibra was, like right here. And like I said, the Hemlibra just takes a back seat. So it's still there, but it doesn't need to work necessarily if you have a breakthrough bleed and the factor VIII products being used.
Courtney,
Yes.
can you give us some feel for the relative cost of Hemlibra compared? I've always, my whole life, have been factor VIII, using recombinant now. But how does the Hemlibra cost measure up?
So I don't know number wise the cost, honestly. The majority of patients that we see are Medicaid patients, so their factor products are always covered. But I can look that up for you for sure. And I will also tell you that The patients that we have on Hemlibra, I think we have 25 now. We have had, I think, 2 of those that have had breakthrough bleeds. So while they do have a factor product at home or a bypassing product at home for backup, only 2 of those patients have had to use it. So, this is especially important, I feel like, with inhibitor patients who were getting ITI and a bypassing agent. We've seen a decrease in cost, I know, with those patients because the factor and the bypassing agent was so much more expensive compared to the Hemlibra.
Are most of those patients self-administered?
I think all of them are that are over 7. So we don't recommend sub-Q under 7 years old, but everyone that's over 7 gives the Hemlibra themselves.
Okay, thank you.
Or their parent. And I do know there is an adult patient on Hemlibra that their spouse gives their shot to them. Which I don't blame them. I'd make my husband do that too. But I will find out about the cost versus factor. Just making myself a note. The other benefit with Hemlibra is the half-life of Hemlibra is about 646 hours. So it's not just lasting a day or 2. It really is in your system for months. And for our patients that are on it, it's truly been life-changing for them. So Stymate, like I said, is on recall, unfortunately, until at least 2022. The side effects are some nausea, flushing, and headache, though I've only had about 2 patients overall that have ever complained of that. Stymate is a nasal spray, and it causes the von Willebrand factor to release, which can raise the factor 8 level. So it's not recommended for hemophilia A patients that have moderate or severe disease. It's usually only used with mild patients. And before we start using the Stymate on any patient, they have to get what's called a Stymate challenge. So they'll come in and get labs drawn, and then an hour later, they'll get labs drawn, get the Stymate, and then an hour later, we draw the labs again just to make sure that their levels are rising and that this medication actually works for them. For the antifibrinolytics, there is Carr and Listida. I don't tend to see side effects in those medicines either. And we use this for preventing bleeding in girls with heavy periods or for dental procedures. Certainly, we use it in conjunction with factors for like a tonsillectomy or any type of really invasive surgery. So, what are complications of treatment? I'm going to start with the last 4 first. Actually, I'll start with inhibitor. Sorry. Inhibitors really are the only current complication that is concerning because it's really the only one that we still see. And what happens is your body develops antibodies toward the treatment of your hemophilia, so either A or B, and that makes your treatment ineffective. So if you're giving factor replacement and your body's not used to it, your body can attack the factor and build the antibodies toward it, and that makes the inhibitor. So then when you give more of this factor, your body keeps attacking it, so the medicine's not going to work for you. That leads to poor control of bleeds, and then you have to use alternative therapies like bypassing agents. There are 2 bypassing agents. Novo-7 is one. It's given through an IV every 2 hours. And FIBA is another. It's given IV about every 8 to 12 hours. And then patients with inhibitors can use Hemlibra, but FIBA and Hemlibra cannot be given together. So if a patient has a breakthrough bleed and they're on Hemlibra, then they have to have Novo-7 at home. And when you have an inhibitor, you can also do something called immune tolerance therapy. And excuse me, with immune tolerance therapy, you're giving your factor product every day to help your body recognize that the factor isn't bad. And you can also have a bypassing agent at the same time. So if you're giving a factor every day, either through a port or peripheral IV, it's very taxing on the patient and their families. It's a lot of work. If it's a younger patient and they're having a lot of problems getting access in their port or with peripheral IVs, it can be very hard. And for providers, it's hard to see your patients go through that, honestly. There's about 20% of hemophilia A patients that have inhibitors. And for hemophilia B, it's only about 1 to 4% of patients. And inhibitors with hemophilia B are actually a lot more severe than inhibitors with hemophilia A. I'm getting a message they're about to close in a minute, so I'm going to try to hurry through the rest of this. So hemophilia A, or excuse me, hepatitis A is considered another complication, but it's just a small risk of transmission. So vaccination is recommended. There have been no hepatitis B transmission since 1985. That is the same for HIV transmission, none since 1985. And for hepatitis C, there have been none since 1990. So I'm going to move through a couple of these. I'm just going to go to the end to important things to remember before they cut us off. So important things to remember: you want to give factor at the first sign of a bleed. When you have increased metabolic states like surgery or trauma, you might need more factor than you normally would. Always use a helmet. Whether it's a bike, scooter, skateboard, anything, you always want to use a helmet. And really, I say anything with wheels. And then ask your hematology office as well if they have a vaccine protocol that they use. We have one in our clinic, which just helps to prevent bleeds when you have vaccinations. And just let your hematology office know what your needs are. I think all of us are pretty open. And then monitor footwear for sure. Any questions?
Very good review. We appreciate your professionalism.
Thank you. Thank you, Rick. Thank you, Guillermo. Thank you, Wendy. I love this little meme here. Well, thank you guys. I appreciate you coming.
So if you are done, thank you, Courtney. That was great.
Thank
I heard of it, because I've been in and out. But you can go out and go back to the main room. We're going to break for lunch, so we'll see everybody back at 1 o'clock. I can't close the rooms because one of the other breakouts, they're in the middle of an important conversation. But feel free to leave and come back, or just stay. And then when it closes, you'll end up back in the main room, and we'll start back up at 1.
Thank you, Jillian.
Thanks.
Bye, guys.